Today I shall discuss about the retention of urine and incontinence. Okay. I may call any roll number while delivering the lecture, and please respond immediately. Okay. Uh, is it clear?
Yes, sir.
Okay. So let us start first with retention of urine. The retention of urine is divided. It may be acute retention, it may be chronic retention. So what is the definition of acute retention of urine? Acute retention is the sudden inability to pass urine. That means all of a sudden the patient will not be able to pass urine without any previous history. And it is painful. What is the definition of chronic retention? Chronic retention is the inability to completely empty the urinary bladder despite maintaining an ability to urinate, which results in elevated postvoidal residual urine volume. That means here in chronic retention, the patient will have the ability, is having the ability, yes, hello, am I audible?
Yes, yes sir.
Okay.
Yes, sir.
Here in chronic retention, the patient will have the ability to urinate, but he or she cannot empty the urinary bladder completely. As a result, there will be increased volume of residual urine in the bladder. Okay? And in chronic retention, remember it, you will have a palpable urinary bladder after voiding, but it is painless. It is painless. But in acute retention of urine, you will get a painful, palpable urinary bladder. Very important. In acute retention, it will be painful, but in chronic retention, it will be painless. Bladder will be palpable after voiding, right? This urinary retention is characterized by poor urinary stream. In chronic retention, you will get, patient will have the ability to pass urine, but the urinary stream will be very poor with intermittent flow. That means during the act of micturition, there will be stoppage of urine. Again, patient will start to urinate. Patient have to go for straining, and after the act of voiding, patient will have the sense of incomplete voiding. That means he will have the sense that still he or she is having some amount of urine in the bladder. Okay? As the bladder will remain full, so it will lead to incontinence, nocturia, and increased frequency. All these things in what is incontinence, what is nocturia, what is increased frequency, I have discussed in my earlier classes. Roll number 10, please respond. Hello. Roll number 10, good morning.
Good morning, sir.
What is incontinence? Already we have discussed in our earlier classes. What is incontinence? What is nocturia? What do you mean by nocturia?
The increased frequency of urine during night.
During night? Okay. So you have to know all these things, meaning of all these terms: incontinence, nocturia, and increased frequency. Right. Thank you. So there are different causes of retention of urine in both male and female. These causes we divide into different subgroups. It may be obstructive cause, it may be infectious or inflammatory, it may be because of drug, it may be neurological or other causes. So causes of urinary retention you can divide into different subgroups, like it may be obstructive cause, it may be because of infection and inflammatory cause. Retention may be because of some drug. There may be some neurological disorders leading to retention of urine and some other causes. Okay. So what are the most frequent causes of acute retention of urine? As we have discussed, this retention of urine may be acute or chronic. So we should know what are the important or most frequent causes of acute retention. Again, in male, we will get some important causes like bladder outlet obstruction. It is the commonest cause. Bladder outlet obstruction is the commonest cause of acute retention of urine in male. Okay. Second common cause of acute retention in male is urethral stricture. Third is acute urethritis or prostatitis, and next is phimosis. So what are the common causes of acute retention in female? These are retroverted gravid uterus, and bladder neck obstruction. Roll number 20, please. Hello, am I audible?
Hello.
Roll number 20.
Yes, sir.
What do you mean by retroverted gravid uterus? What is gravid uterus? Can you hear me? Roll number
Yes, sir.
20. What do you mean by gravid uterus? What is gravid uterus? It's a pregnant uterus. No, pregnant uterus is the gravid uterus. So what will happen in gravid uterus? Usually this nulliparous uterus, in nulliparous, what is the position of uterus? Antiflex anteverted. Antiflex anteverted. Okay. So in some gravid uterus, it will be retroverted. That means posteriorly. Okay. Uh, in details, you will know in gynecology department. So this retroverted gravid uterus may lead to retention, acute retention of urine in female. Okay. Thank you. And
Yes.
next cause of acute retention in acute retention of urine in female is bladder neck obstruction, though it is rare in female, but it is okay. There are some causes which you may get you will get in both in male and female. Okay, uh, these are retention may be because of blood clot, either in the bladder or obstructing these outlet, internal urethral meatus. Then urethral calculus, ruptured urethra, neurogenic, that it may be because of injury or disease of the spinal. There may be injury to the spinal cord, there may be disease of the spinal cord, which may lead to retention of urine. Smooth muscle cell dysfunction, then fecal impaction. Remember, fecal impaction is very, very common, okay, uh, of acute retention of urine both in male and female. Particularly, this fecal impaction you will get in extreme ages, elderly people and in children. Okay. Then anal pain. If there is severe pain in and around the anus, there will be reflex spasm, sphincteric spasm, and patient will have retention of urine. Common causes, if a patient is having acute fissure in ano or following hemorrhoidectomy or following any surgery in and around the anal canal, patient will have severe pain and there will be reflex spasm and which may lead to acute retention of urine. And some analgesic may lead to following in post-operative patient, we may use some analgesics which may lead to retention. Some drugs may lead to acute retention, we will mention later on, and spinal anesthesia. Following spinal anesthesia, some patient may develop acute retention. That means they may not be able to pass urine. Okay, so these are the most frequent causes of acute retention. Some are specific for male, some are specific for female, and there are some common causes which are present both in male and female patients. You remember, this retention of urine is a very common condition. Uh, Whether you are doing general practice or you are working in surgery or in medicine or in ONG department or in the pediatrics or in psychiatry, anywhere, wherever you are working, you will get some cases of retention of urine, and you should know how to deal with this patient, and you should know what is acute retention, what is chronic retention, and how to treat it, how to treat this condition. You have to give immediate relief to your patient. And you see, if you cannot manage it properly, there may be some complication following it. Okay, so it's very important to know how to diagnose and how to manage this acute retention. So irrespective of any specialty, wherever you are working, whether being a very junior uh, staff or very senior staff, you have to encounter this. You have to face the retention of urine, irrespective of any specialty. right? So what are the obstructive causes common in man, common in male? Okay, obstructive causes, very common obstructive causes are benign prostatic hyperplasia, very important in elderly people. We shall discuss benign prostatic hyperplasia in our in another class. Meatal stenosis, paraphimosis, phimosis, and prostatic cancer. All these things, benign prostatic hyperplasia, meatal stenosis, paraphimosis, phimosis, prostatic cancer, this will lead to some sort of obstruction in the either in the bladder neck or internal urethral meatus or into the external urethral meatus. Okay, uh, and will ultimately lead to retention of urine in male. Okay, then what are the obstructive causes of acute retention of urine in female? These are organ prolapse. Organ prolapse means prolapse of the pelvic organ, rather. It should be prolapse of the pelvic organ. What are the roll number 36? Hello? Roll number 36? Can you hear me?
Yes, sir. Yes,
Uh,
sir.
Name some pelvic organ, female pelvic organ. I am asking
Sir,
very simple
uterus.
question. Name some
Sir, uterus, urinary bladder,
urinary bladder, uterus in female and in both male and female.
sir, bladder, sir.
Urinary bladder, then rectum. Okay, so these are the different organs. Besides this, some other organs are also there. You'll get in the pelvis. So in female, thank you. In female, what will happen? There may be because of repeated pregnancy or trauma into the pelvis. Okay, there may be prolapse of the some of these or any one of these pelvic organ. So there may be prolapse of urinary bladder itself, okay, and forming which is known as cystocele. There may be prolapse of the rectum, which is known as rectocele. There may be prolapse of the uterus itself. So that means this bladder in cystocele, urinary bladder is coming downwards, forming a bulge into the vaginal wall or okay. In rectocele, rectum is coming downwards. In uterine prolapse, uterus is coming downwards. So this, when it is coming downwards, when there is prolapse, there may be some pressure about the female urethra, right? Female urethra or in the bladder neck, and which may lead to retention of urine and causes is the obstruction, okay, leading to obstructive type of urinary retention. Okay, in some pelvic mass like gynecological malignancy, uterine fibroid, ovarian cyst, these may lead to obstructive type of urinary retention. Again, another cause, very important cause in pregnancy is retroverted gravid uterus may lead to acute retention of urine in female, right? Then there are some obstructive causes which are present both in male and female. These obstructive causes are bladder calculi. That means vesical calculi. Okay. This calculi may enter into the internal urethral meatus, leading to obstruction, and patient will have acute retention. Okay. Then bladder neoplasm may lead to obstruction. Then again, I have mentioned fecal impaction leading to acute retention in both sex, male and female. Then gastrointestinal or retroperitoneal malignancy or mass, strictured urethra, then foreign bodies, and stone again, stone in the urethra, urethral stone. Okay, there may be infection. This stone may be impacted into the urethral meatus and it will lead to acute retention of urine. Patient will be in severe distress. Okay. So these are the causes, common causes for which you will get in both male and female, right? Then next cause of acute retention is infection. It may be infectious and inflammatory also. So what are the infective condition in male lead to acute retention? These are balanitis, prostatic abscess, and prostatitis. Okay. Just here again. Roll number 50. Hello. Can you hear me?
Yes, sir.
What
Yes,
is
sir.
your name? What is your name? Roll number 50.
Sir, my name is Partho Pratim Murali.
Acha. Partho, do you know what is prostatitis?
Yes, sir. Inflammation of the prostate gland.
Prostate gland. Yes, right. So in prostatitis, what will happen is a male pelvic organ, okay, and so the prostate
Yes, sir.
prostatic urethra is passing, is not it? So when there is inflammation or infection of the prostatic gland, it will be edematous. Okay, so what will happen? It will be edematous and it will be very much painful. So there will be this inflamed prostate may press over the prostatic urethra. Okay, and
Yes, sir.
following this, there may be acute retention of urine. So you please repeat what are the causes of inflammatory causes or of acute retention of urine in men. You just repeat these three. Just now I have mentioned. It is you just see the slide and tell.
Balanitis, prostatic abscess, and prostatitis.
Yes, good. So next is there are some inflammatory or infectious causes in female which may lead to retention of urine. These are acute vulvovaginitis, vaginal lichen planus, and vaginal lichen sclerosis. Okay, there are some common condition in both male and female. Often you will get which may lead to retention of urine. These causes are cystitis, then periurethral abscess, and urethritis. Rule number 80. Hello? Hello? Can you hear me? Roll number 80. Hello? Hello? Roll number 80. Absent. Whether attending the class or not. Okay, I'll see it later on. Roll number 84. Roll number 84.
Yes, sir.
What is cystitis? What is cystitis? You are roll number 80 or 84?
Sir, 84.
84. What is cystitis? Have you heard this term earlier?
Sir,
Yes or no? You just tell. Don't spend time. No problem. It's not that you will know everything. What is cystitis?
hello.
Huh.
Sir,
What is
inflammation of mesenteric cyst.
mesenteric cyst? No. It is related with bladder. Inflammatory condition or in following infection of the urinary bladder. When there is infection of the wall of the urinary bladder is known as cystitis. Okay?
Yes, sir. Yes, sir.
And periurethral abscess, that means there will be abscess formation. There are some periurethral gland. There may be blockage of the gland, and there may be superimposed infection may lead to abscess formation around the periurethra, means around the surrounding the urethra. Is it clear? Is it clear?
Yes, sir.
So
Yes, sir.
any abscess around the urethra, which is called periurethral abscess, maybe because of obstruction of the periurethral gland and superimposed infection, there may be collection and abscess formation. And if a patient develops this periurethral abscess, it's a very painful condition. Okay, there will be following infection and inflammation. There will be inflammatory changes. Okay, and ultimately patient will have retention of urine. And following urethritis also, there will be in some patient you will get retention of urine. Roll number 5. Hello. Roll number 5. Roll number 5. Can you hear me? Roll number 5. Hello. Absent. Roll number 18. 18. 18. Roll number 18. Not attending classes. Okay, I will see later on whether you have entered or not. Roll number 18? No. Roll number 52? Roll number 52? 52.
Yes, sir.
You are 52.
Yes, sir.
You are 52.
Yes, sir.
Okay.
Yes, sir.
You tell me what are the cardinal signs of inflammation?
Sir, rubor, tumor, dolor, calor, and loss of function.
Acha. So there will be swelling and edema formation, all these things. Is not it? In and around the
Yes, sir.
inflammatory site. And this will compress the surrounding structure. If there is urethritis or periurethral abscess, ultimately there will be swelling, okay, and abscess formation, okay, and will lead to retention of urine. Okay, thank you. What are the drugs leading to acute retention of urine? That means drug-induced retention. Regularly, we are using some drugs which may lead to retention of urine. These are anticholinergic drugs. antipsychotic drugs or antidepressant drug, okay, agents, which will in psychiatry department we are using all these things. So some patient using these drugs may develop retention of it. We are using some opioids uh, and some anesthetic agents, which also may lead to retention. Benzodiazepam, benzodiazepines also may lead to acute retention. Non-steroidal anti-inflammatory drug. Roll number one. Roll number one, please. Hello. Hello. Roll number one. Can you hear me? Roll number one. Roll number 21. Roll number 21. 21. 121 absent. Roll number 31. Roll number 31. Roll number 41. Hello. Roll number 41.
Yes, sir.
Okay. You tell me. You name some non-steroidal anti-inflammatory drugs. You name some.
Sir, aspirin,
Aspirin.
paracetamol,
Okay. Any other?
ibuprofen,
Huh? Okay. Okay. So these are the non-steroidal anti-inflammatory drugs, and following use of this drug, in some patient, some patient may develop acute retention. So while you are dealing with a patient of retention of urine, you have to ask so many questions. You have to take the history properly, whether particularly drug history, whether he is or she is getting any anticholinergic drug, antipsychotic drug, whether he has undergone any anesthesia or not, and getting any anti-inflammatory drugs or not. Okay, whether he or she is getting any calcium channel blocker, that means antihypertensive. Can you name one calcium channel blockers? Anyone? Hello? Anyone? CR, you tell. CR, please.
Sir, amlodipine, nifedipine.
Nifedipine. These are the calcium channel blockers, and some hypertensive patient using this and may present with retention of urine. And antihistaminics and alcohol. Remember, you will get in emergency. You are doing duty in your emergency department, and some patient may come with retention of urine, and if you take the history, you will get this patient has consumed alcohol, and this alcohol may be the only cause of retention of urine in that particular patient, right? So these are the different drugs which may lead to retention of urine: anticholinergic drugs, opioids, benzodiazepine, non-steroidal anti-inflammatory drugs, dextrosol relaxant, calcium channel blockers, antihistaminics, and alcohol. Very important. Then there are some neurological causes of acute retention of urine, and more often causing chronic retention, but may lead to acute retention of urine also. And it may be autonomic or peripheral nerve. There may be autonomic or peripheral nerve involvement. It may be because of some cardiovascular disease, following CBA, multiple sclerosis, neoplasm, normal pressure hydrocephalus, and Parkinson's disease. Okay, there may be retention. there may be involvement of the spinal cord, there may be disc prolapse, intervertebral disc disease or prolapse, meningomyelocele, okay, spina bifida occulta, spinal cord hematoma, abscess, and very important is spinal cord injury or spinal cord trauma. Then spinovascular disease, transverse myelitis, okay, tumors, Coda equina syndrome. All these may lead to retention of urine. Other causes in male, there may be injury into the penis leading to fracture and laceration of penis. Obviously, will lead to these are in the group of other causes. So, any injury in and around the penis or over the penis, this means penile trauma may lead to fracture or laceration, and patient may come with acute retention. In women, postpartum complications like increase, that means instrumental delivery, prolonged labor, following cesarean section, okay, and in both male and female, there may be pelvic trauma, iatrogenic or psychogenic the trauma may be there, may lead to psychogenic disorder may lead to retention of urine. Okay, so what are the symptoms patient will have? Obviously, in acute retention, patient will come and say there is difficulty in starting to urinate. He is unable to start, unable to pass urine. Okay, and some patient may come with post-micturition dribbling or poor stream of urine. This second complaint you will get in chronic retention, those who are having chronic retention. Then there will be increased abdominal pressure. Patient have to strain to pass some amount of urine, and there will be increased frequency of micturition, nocturia. All these things you will get in chronic retention, and those some patient will come with symptoms of acute retention. That means there will be difficulty to initiate the urine, and they will have severe pain. Pain will be there over the lower abdomen. And in both the cases, in acute and chronic, the bladder will be visible. You will get a distension, globular swelling over the lower abdomen arising from the pelvis. Lower abdomen over, that means over suprapubic area, and this bladder will be palpable. And to know why, know whether it is bladder or not, you have to percuss over the abdomen. And what you will get when you will percuss over the swelling in the suprapubic area, it will be dull on percussion. Why? Because it contains the urine. Okay, fluid. That means urine. Okay, and in chronic acute condition, if it is because of acute condition, this distended bladder will be tended. Okay. The BPH is one of the commonest cause of urine retention. What you will get all the signs symptoms of BPH. That means lower urinary tract voiding symptoms you will get. That means you get increased frequency, urgency, nocturia, straining to void, weak urinary stream, hesitancy, sensation of incomplete bladder emptying, stopping and starting of urinary stream. All these things, all these symptoms of LARTS, which we have discussed earlier, you get in BPH. Usually causes of urinary retention, but usually these people come to attend when they get an acute and chronic retention. You see, a patient of BPH will have chronic retention. That means they can pass some amount of urine, but cannot evacuate the bladder completely. Okay, so they will have increased frequency, they will have urgency, they will have nocturia, they have to strain to void, they will have weak urinary stream, hesitancy, okay, and all these things, these symptoms they will have. But sometimes they may come with some of them may complain that they cannot pass urine at all. That means they developed acute, they are having chronic retention following BPH, but was able to pass urine, but all of a sudden they have noticed they cannot pass urine. That means they have developed acute on chronic retention. Okay, is it clear? So history taking is very, very important. In history taking, you have to pay attention on following points, like course of development of this disease, of this condition, including onset and progression, whether this patient is having any fever, any previous episodes, any history of benign prostatic hypertrophy, any complaints of lower urinary tract symptoms, that means LUTs, then past medical history, drug history, neurological disease, other medical condition, hypertension, all these things, and ask about alcohol, constipation, long travel, low fluid intake, and high fluid intake. Both are important. You have to take all these things you have to take special precaution while taking this history. Okay. Then examination, whether you have to know whether your patient is warm or that means having fever or not. In abdominal examination, what you will get? You will get a tender enlarged bladder, already I mentioned, with dullness on percussion, well above the symphysis pubis. It may extend up to the umbilicus. Okay, and this swelling will be dull on percussion and it will be tender. Then you have to examine the perineum, external genitalia. In male, you have to see whether this patient is having phimosis or not, whether this patient is having, you have to see the meatal opening, whether the meatus is stenosed or not. That means whether this patient is suffering from meatal stenosis or not. You have to see, look for any signs of infection in the genitalia. This infection may lead to retention. In female, you have to look for presence of cystocele, rectocele, uterovaginal prolapse, and to know all these things, you have to go for the vaginal examination. You have to go for the pelvic examination to know the patient is suffering from pelvic mass or not. Okay, you have to also look for any valval infection or if there is any inflammatory changes or not. You have to do DRE and PR examination or PR examination in male. What is DRE? We have discussed rule number 9. Can you hear me? Rule number 9. Hello? Hello? Rule number 19. Rule number 19. Hello? Hello? Rule number 19. Roll number 29. CR, hello? Hello, CR?
Yes, sir.
You
Yes, sir.
please note down the roll number. I'm having this roll
Okay,
number
sir.
also, and you see whether they have entered into the class or not, and you let me know. Huh?
Okay, sir.
And
Yes,
if
sir.
anyone has entered, definitely some of them has definitely entered, but then not listening to this class. And tell them to send me the reason why they were not in the class. Okay.
Yes, sir. Yes, sir.
Roll number 29. Roll number 39. Hello. Hello. Roll number 49. 48. 58. 68.
Yes, sir.
Good.
68.
68. What is DRE? What is the full form of DRE? DRE. I have mentioned in my class several times. DRE examination.
Sir, digital rectal examination.
Good. Digital rectal examination. Digital rectal examination. So in a case of the retention of urine, you have to go for digital rectal examination in male particularly. Why? Why you have to go for digital rectal examination in a patient of retention of urine? Look for whether your patient is having enlarged prostate or not. Okay.
Yes.
So this is very important examination. Huh? So you have to go for digital rectal. If you don't mention this,
Yes.
if you don't do it, you will not be able to make the diagnosis why your patient is having retention of urine. So digital rectal examination, with which finger you will do this digital rectal examination? With which hand? Left or right hand? Right hand. Definitely right hand. Okay. Right
Yes.
hand you will use. Which finger? You cannot introduce your all fingers. It's not it.
Index.
Index finger. Okay. Index finger you will use. Any precaution you want to take?
Sir, will lubricate the gloves.
That
Fingers.
means you have to wear the gloves and you have to
Yes.
lubricate your finger with some jelly. Okay.
Yes.
Okay. This you read how to do this digital rectal examination. All of you, please read digital rectal examination. Very important. Huh? Then you have to go for neurological examination to know whether your patient is having any neurological defect or not, whether he is suffering from neurogenic bladder or not. Okay. Then you have to go for some blood test. Total count, estimation of creatinine, then glomerular filtration rate, estimated glomerular filtration rate, blood glucose is very important, and PSA, prostate specific antigen. And you see this blood you have to take before doing this prostate message or the digital rectal examination if you want to do this PSA. Okay. So these are the blood tests. And what are the investigation, other radiological investigation you have to do? Very, very important investigation is ultrasonography, commonly used, and it will provide you information regarding the volume of the post-residual urine and whether your patient is suffering from hydronephrosis. You see, in chronic retention of urine, there is post-voidal urine, and there will be retrograde pressure, and there may be hydroureter, hydronephrosis, all these things. So you have to look for it. Okay, in chronic retention of urine, there will be retrograde pressure effect. So you have to, these things you will be able to know from your from the ultrasonography of the cavity region. Okay, then CT you can do to exclude the any intra-abdominal mass, MRI and CT brain to CT brain to exclude space occupying lesion in brain. You see, the CT MRI is not routinely used, but ultrasonography in all the cases of particularly of chronic retention you have to do, you should do. But MRI, suppose if you suspect a patient is having some neurological problem, then only you can go for the CT, and having suspecting abdominal mass, you can go for this CT brain. You can go for the, if you think there may be some pathology in the spine, you can go for the MRI of the spine, and you can go for the cystoscopic examination, okay, and intravenous pyelography later on, not always required, okay, but cystoscopy you should do. Then how will you manage a patient of retention of urine? And you see, this acute retention of urine is a very distressing condition, is a very painful condition. So what you have to do, you have to manage it immediately. That means, what is the management? Patient is unable to pass urine. That means you have to decompress the urinary bladder immediately with a suitable catheter. How will you decompress the bladder? You can decompress the bladder with catheters. And this size of the catheter should be educated, suitable one. Okay. So how to decompress? You have to introduce a catheter into the urinary bladder. What are the different routes, or how to evacuate? Very, very common, usual here, you have to catheterize this patient through the urethra. It may be penile urethra or in female. Whether it is male or female, you have to use this penile catheter. You have to introduce the catheter through the urethra. And in most of the cases, you will be able to pass it into the bladder, and gradually this urine will be evacuated, and then crisis will be over, and you can investigate. You will be able to know the cause of retention. If you cannot negotiate the urethra, catheter through the urethra into the bladder, then what to do? How to evacuate the bladder? How will you decompress the bladder? You can decompress. Urethral catheterization failed, then you have to go for a suprapubic catheterization. Okay, suprapubic catheterization. Okay, how to do it we can discuss later on. And if the prostate is palpable in digital rectal examination, you have to start some drug later on, and neurogenic bladder related urine retention should be managed with clean internal self. So if the patient is having, if you think he is having neurogenic bladder or the spinal injury or the, okay, in that case you can go for the intermittent self catheterization. Okay, then you should know little bit about urethral catheterization. It's a very common procedure. Everyone have to know it. Everyone should do it, and you will also do it. And it's a very important procedure. If you do any mistake while doing the catheterization, patient will suffer a lot. There will be so many complications following catheterization, or you may not be able to negotiate the urethra catheter into the bladder. So what you should do in a very short, I shall mention, you should clean the genitalia with the soapy antiseptics. You have to clean, okay? And what are the things you should have before catheterization? You should have a standard size self-retaining catheter. Self-retaining catheter, usually Foley's catheter, two-way Foley's catheter. Then you should have sterile gloves. You should have soapy antiseptics. You should have sterile gauze. You should have sponge holding forceps. You should have lignocaine, 0.5% lignocaine jelly, and you should have syringe loaded with normal saline, 10 ml syringe loaded. You should have a Eurobag, okay? All these things you should have. Then you wash your hand, wear the sterile gloves, then clean the external genitalia, male or female external genitalia thoroughly with soapy antiseptic, and you should not hold it. You should not touch the external genitalia, but you should take then how to clean it? You should take the help of sponge holding forceps. With sponge holding forceps, you hold the sterile gauze, then take the antiseptics and clean this area thoroughly. Clean this area thoroughly. Then after cleaning, you should hold this penis with left hand or left hand if the patient is male, and you should introduce the jelly, like lignocaine jelly, into the urethra, so external urethral meatus, and push some amount of jelly inside the urethra and massage it. You should allow the jelly to go downwards through the urethra and massage posteriorly over the penis, so that whole length of this urethra is through the whole length this lignocaine pass, and this will help to dilate the sphincter, anesthetize the sphincter. Then what you have to do? You have to take a small size Foley catheter and gently you pass it through the negotiate it through the external urethral meatal opening, and pass it gradually. You have to pass the full length. Ideally, you should pass the full length of the catheter, okay? And then urine will start to come out, okay? And then you have to inflate the balloon. Inflate the balloon of the catheter with the saline which you have taken in a syringe. So through another channel. There are two channels. in the two-way Foley catheter. So in the separate channel, you introduce this NS and this will inflate the balloon which is inside the urinary bladder, and then gradually you pull the catheter little, pull the catheter, okay, outward, okay, and thus this catheter will remain inside the urinary bladder and it will drain the bladder, distended bladder, okay, and it will allow the urine to come out from the urinary bladder. So urethral catheterization is, this is in short, you have to see this catheterization in the ward. You should come into the ward and you see how they are doing. Okay, and of course you have to maintain the privacy. You have to maintain the privacy while doing the catheterization. Okay. So if the catheterization, urethral catheterization fail, then what you have to do, you have to go for the suprapubic puncture. In the suprapubic region, you have to do this. And what you have to do? The skin, in the suprapubic region, you have to anesthetize the skin, fossa, okay, and suprapubic space, okay, with lignocaine, and you have to, of course, you have to see whether the bladder is distended or not by palpation and percussion. You have to confirm it, and then you have to confirm whether the distended swelling is bladder or not. You have to aspirate. You have to introduce this needle with the syringe into the bladder and aspirate it. If the urine is coming out, that means it is the clinically it is confirmed that it is the bladder. Then what you can do, you can introduce a large bore needle into the suprapubic area. You place it from the, introduce this wide bore needle to the suprapubic part into the bladder, and then so you pass a fine catheter, and which will go entered into the bladder and then secure the position of this fine catheter. Otherwise, you can use a plastic trocar, suprapubic trocar and cannula, which is available in the market. You have to show that. Then you have to make a small incision into the suprapubic area after anestheting this part, and this then so this you have to remove the cannula, trocar, and then introduce a 12 size or 14 size Foley catheter through it, and then the remove all these things and inflate the balloon, and this catheter will remain in situ. Okay, so contraindication of urethral catheterization, you know, well, if you suspect there is urethral trauma, you don't go for the urethral catheterization. Patient is, if the patient is having pelvic fracture, don't go for the, remember it, in pelvic fracture patient, don't go for the urethral catheterization. If there is blood in meatus, don't go for the catheterization. In digital rectal examination, if you get this prostate is riding high, not in normal position, high riding prostate, don't go for the urethral catheterization. Okay, then you have to go for the treatment of the cause. If BP is the commonest, if BP is the cause, you have to go for the medical therapy, and then TURP, transurethral resection of prostate, will discuss. If there is stricture urethra, you have to go for urethroplasty. If there is stone, vesical stone is the cause of retention, you have to go remove the vesical stone. Okay. Then this is all about the retention of urine. You go through it. You go through the urethral catheterization, but remember, one, not to go for urethral catheterization. If you suspect there is rupture of urethra, pelvic fracture, blood in the meatus or high riding prostate, don't go for catheterization session. Remember, what not to do, you should know. Okay, so this is all about the retention of urine, very common topic, you got through it. And urinary condition, I shall send you the slide of